Inviting my co-instructors, Dr. Aditya Bajaj, Dr. Soham Bosak, Dr. Binoy Pillai, Dr. Aditya Pradhan, and Dr. Paras Mehta. So our key speakers is this Dr. Vishal Jhanji, and he will be talking on atypical microbial keratitis.
Okay, you got it. Should I start?
Yes, sir.
Okay, thank you. Good morning, everyone. I want to thank the organizers for inviting me to this session. I'm going to present atypical microbial keratitis management. This is going to be a case-based discussion mainly. My name is Vishal Janji. I work at the University of Pittsburgh. I don't have any financial disclosures relevant to this talk. So how do we define atypical microbial keratitis? So in general, corneal infections that are caused by microorganisms that are not commonly encountered in clinical practice. That's a very relative definition depending on where you live and practice. Something that is very commonly seen in certain parts of India or Southeast Asia might not be as common as in North America or even South America. But in general, we have been able to identify some of the pathogens that are causing atypical keratitis more often than others. The risk factors are about the same as you would see in any other patients with microbial keratitis, which is trauma and contact lens wear, ocular surface disease. The main difference is clinical presentation. So these patients, they are themselves sometimes not sure what is bothering them. So because of the nature of the ulcer and the symptoms, it's indolent and chronic, difficult to diagnose, very important to have high index of suspicion. Of course, something that is difficult to grow is going to be difficult to kill as well. So they are difficult to treat. And the prognosis is usually not good, and many patients will require surgery. So this is an incomplete list of atypical microbes. I'm going to discuss 3 cases, one with atypical mycobacteria, Nocardia, and Microsporidia. Of course, something that is unfortunately more common, like Pythium and Alternaria, and even Achromobacter, they can be seen depending on where you practice. The first case actually is borrowed from a friend of mine, Dr. Charles McGee from New Zealand. This is an 85-year-old healthy female who presented 2 months after uncomplicated cataract surgery with decreased vision and a stromal infiltrate with 2+ cells and hypopium without any hypopium or vitritis. So patient was admitted for fortified antibiotics, cultures were negative, but she was getting worse. So actually, the surgeon went ahead and performed anterior chamber washout, vitrectomy, and injection of intravitreal vancomycin and ceftazidime, basically covering whatever they could in the face of negative microbial cultures. Patient was also put on oral doxycycline, ciprofloxacin, and prednisolone was added. Patient showed signs of improvement as was discharged on day 16. This is how the patient looked like, but she continued to have waxing and waning course. Again, as I said, it's an indolent course. Corneal biopsy was done, which is usually the last resort for a cornea specialist, which was negative as well. Ultimately, a patch graft was done in order to make sure the infection area is taken care of, but the infection actually came back. Now, finally, the keratectomy cultures, they revealed Mycobacterium cheiloni, which was resistant to ciprofloxacin and doxycycline. So, which means that probably the corneal biopsy was not very deep in the first place. The actinic graft was removed. The bug was fortunately sensitive to clarithromycin and tobramycin and linezolid. Resolution of keratitis took another 2 months. So it took a total of 10 months from the time of presentation. Just a bit about the non-tuberculous mycobacteria. They're aerobic non-motile AFBs found in soil and water. They can colonize human skin and bodily fluids. They're usually associated with systemic infections, especially when there is incomplete sterilization of instruments and fluids. In terms of eyes, we do see a lot of infections in the cornea, especially post-LASIK. In fact, any patient that walks in with a post-LASIK infection, we are told to believe that it's going to be mycobacteria until proven otherwise. Clinical presentation, days and weeks after the initial insult. We have LASIK patients, for example, with mycobacteria who presents years after the initial surgery with absolutely no problems at all. You can see single or multiple granular opacities. They're usually stromal, and that's why it's very difficult to obtain adequate samples. This is another patient published in the literature with a mycobacterium infection. So diagnosis with classical tools, you can use acid fast stain, and also LG medium. If you have access to McConkey-Jaeger or Middlebrook, you can use that as well. PCR is not readily available, at least in the United States, but now there are new tools, which is of course a completely different topic, which can facilitate the diagnosis with PCR. Treatment, as I mentioned, takes a long time to diagnose, even longer to treat. Fortunately, clarithromycin works in many of these patients, and oral clarithromycin has been shown to clarithromycin topical, has been shown to have good penetration even through intact epithelium. It can actually be species dependent as well, and it's usually recommended to start more than one drug at a time. Steroid use is going to make the infection worse. And as I mentioned and showed in the case, you might have to resort to a full thickness or a lamellar transplant. So the second case is a 15-year-old male, a young boy from high school, poor contact lens hygiene, presented to another hospital with poorly healing corneal abrasion, was started on antibiotic and steroid ointment, developed pain and photophobia after that, and presented to us with feathery margins, looking like infiltrate. You can see. Now, of course, I can only describe to you, when you scrape this infiltrate, you have that gritty feeling once you run your blade or your needle on it. Needless to say, you can see the microbiology slide as well. This was a case of nocardia. Initial treatment, before the diagnosis was made, was with NSAID and tobramycin. Fortunately, with good scraping, we could see nocardia in the scraping itself. And we performed a 16S ribosomal DNA sequencing to confirm the species. Topical amikacin was started, and symptoms started to get better in 2 weeks. Although the patient got better, we never started steroids in a fear of recurrence. And treatment was continued for a good 2 months before resolution. This is another patient from the literature of nocardia. You can see multiple opacities. They're sort of anterior stromal, and it does not have a classic cracked windshield appearance, but high suspicion and is important in such cases. A little bit about nocardia again. Aerobic gram-positive non-motile filamentous bacteria, very prevalent in Southeast Asia. It can colonize tissue around teeth and associated with trauma as well. Ocular infections are mostly keratitis, can cause conjunctivitis, scleritis, infections of lacrimal glands, orb cell, and also endophthalmitis. Clinical appearance is classically patchy, raised pen-sized head size infiltrates in a wreath fashion. Satellite infiltrates might make you think that this is fungal keratitis, but they are quite superficial actually compared to a fungal keratitis. So microbial diagnosis is not very difficult. Fortunately, gram-positive bacteria stained with Gimza, you can do a KOH with CFW or acid-fast dyes as well. They're slow growing again, and PCRs are not readily available. Average reported treatment time is about 6 weeks. Drug of choice is fortified topical amikacin. You can encounter resistance though. Steroids again will lead to worsening of infection and will delay the diagnosis and treatment. There is some possible role of cross-linking using rose bengal therapy, just because rose bengal has been shown to be beneficial in vitro. The last case is a 34-year-old male who presented with 10-day history of bilateral pain and conjunctivitis-like picture. The only diagnosis, history that we found was he had been to a water park, and he specifically said that he was drenched and a lot of water went into his eyes. He was started on topical ganciclovir by somebody else, but when he did not get better, he was sent to us. This is how he looked like clinically actually in both eyes. So we simply scraped off the epithelium and we saw microsporidia. This case was diagnosed about 6 years ago, and we actually got a call from the CDC about the details of the case. So microsporidiosis, unlike India or Southeast Asia, is not very commonly seen in the United States. These are spore-forming unicellular opportunistic pathogens. They are, you can have, this is a large group of pathogens actually. They're endemic to South and Southeast Asia. As I mentioned, they can cause epithelial keratoconjunctivitis, which is still fortunately the most common form and relatively easy to treat, but they can cause deep stromal keratitis, scleritis, and endophthalmitis. The deeper the infection with microsporidia, the worse the prognosis and visual outcome is going to be. This slide basically shows the life cycle of intracellular development of microsporidia, you can see, depending on the species, they can actually form spores, or they can release the mature spores into the body. Clinical presentation, as you saw in the picture, is exactly the same. Epithelial lesion with stuck-on appearance, variability in staining with fluorescent, and the presentation can be from subepithelial punctate infiltrates, adenoviral-like picture as well. That is what our patient was told. Microbial diagnosis, as I mentioned, gram-positive, is shown in the slide earlier, stains well actually with gram stain and silver stain and KOH and CFW as well. For deeper stromal infiltrates, you might need a corneal biopsy and a high index of suspicion. It can be detected on IFSA as well, and PCR is still not available in the US for now. Treatment, our patient got better just with epithelial debridement in both eyes. You can use topical fluoroquinolones. A lot of work has been done from India, especially from L.V. Prasad, showing the usefulness of famagillin, topical azoles, and PHMB and chlorhexidine in these patients. You can actually use albendazole for some of the species. Topical steroids have been shown to be beneficial for inflammatory component, especially when these patients present with uveitis. So that's the slide for the references. Thank you so much for your kind attention.
Very nice presentation, Dr. Vishal.
Thank you.
I just had a quick question. Usually, nocardia is not a part of these infections so often. And that was very interesting to see with multiple nocardial infiltrates into the cornea.
Yeah, I agree. I mean, nocardia, classically, the teaching is that it'll have the cracked windshield appearance. And frankly, I have not seen nocardia in too many instances where it happened due to contact lens wear.
Exactly.
We did think that it was fungal keratitis, but as I mentioned, once you start scraping the edges, you can feel that grittiness, and then you know that this is simply not fungus, unless it is pigmented, which it was not. So it was an unusual presentation.
Very, very unusual.
Thank you.
Thank you.
Okay, now we'll be going to our main courses on these ocular bonds. So we all know that these ocular bonds are one of the true ophthalmic emergencies, and this is the only ocular condition where history taking and examination should be delayed and start immediate management without proper assessment of the injuries. We should have coordination with physician, surgeon, and psychiatrist may be required. And in bilateral chemical exposure, it is especially devastating, often resulting in complete visual disability. Proper management in the acute stage is the most important, and that leads to, that means proper outcome. If we don't manage properly, then there will be chronic inflammation, which often causes fibrosis and continues to cause damage to the conjunctiva and limbal stem cells. All these lead to subconjunctival fibrosis, which leads to symbliferon formation and pharyngeal shortening with entropion formation. There will be goblet cell deficiency, which will result in this mucus secretion dysfunction and dry eye formation. So the course outline is this, like the starting from ocular bond classification to visual rehabilitation. So our first speaker will be Dr. Aditya Pradhan. He will be talking on ocular bonds, but unfortunately Dr. Paras Mehta, she has to go to another session. So over to Dr. Paras Mehta. She will be talking on lead visual rehabilitation in unilateral ocular bond cases by different modalities of treatment. Over to you, Dr. Paras. That's it, or here only. Dr. Bina, can you come here, please?
Is it on? Yeah. Good morning, everyone. Thank you, Dr. Tuhin, for accommodating this to talk a little earlier than the beginning part of the session. So we are going in a reverse order. I will be talking to you about visual rehabilitation in unilateral burns cases. Yeah. So my subject is late visual rehabilitation in unilateral ocular burn cases by different modalities of treatment. As we know, unilateral chemical burn sequelae would be pannus formation, symblepharon, corneal stromal scarring and thinning, fornical shortening, restricted eye movements due to subconjunctival fibrosis, total or partial limbal stem cell deficiency, at times keratinization and loss of an eye. So we need to decide the strategy to tackle the issues which may be directly involved with the visual and functional outcomes. We all know that limbal stem cells are responsible for the regeneration of corneal epithelial cells and the maintenance of the integrity and transparency of the cornea. Destruction of these limbal stem cells or limbal stem cell niche or both can lead to limbal stem cell dysfunction and limbal deficiency. Limbal stem cell deficiency results in delayed epithelial wound healing, recurrent epithelial erosions, and loss of vision. Fortunately, limbal stem cell transplant can restore normal epithelial phenotype and re-establish stable corneal surface. In patients with unilateral limbal stem cell deficiency, the healthy fellow eye can act as a source of donor limbal stem cells, which makes the procedure autologous and obviates the need for any systemic immunosuppression. However, in bilateral cases, one can use the tissue from another person, making it an allogenic tissue with its own source of issues to be addressed post-surgery. They would need systemic immunosuppression kind of lifelong. So these are the clinical pictures of limbal stem cell deficiency. They present with conjunctivalization of the cornea or pannus formation, recurrent epithelial breakdown, and inflammation of the ocular surface, loss of transparency of the cornea leading to impairment of the vision. If we look at the causes of limbal stem cell deficiency, almost 80% are contributed by chemical burns in unilateral injuries. So if we look at the clinical pictures, unilateral chemical burns can present with total limbal stem cell deficiency, with central corneal scarring, with less scarring, sometimes with partial limbal stem cell deficiency, as you can see here in this picture, at times with symblepharon formation with partial central corneal stromal haze. And here you can see that there is a shortening of the fornices as well, and sometimes very significant fibrosis leading to symblepharon. This is something unusual. Anyway, I just like that. We look at the algorithm for management of limbal stem cell deficiency. If we see that, the primary focus for treating any patients is you have to control the inflammation, and then you can divide them into partial limbal stem cell deficiency and total limbal stem cell deficiency. Here in this particular talk, we would be focusing on basically the unilateral chemical injuries leading to limbal stem cell deficiencies. As you can see here, they can be treated by various means. If it is, some can be treated with medical management. If they are in the initial part, they can be treated with just an AMT at times, or a symblepharon release and conjunctival autograft, while the ones which have limbal stem cell deficiency, significant limbal stem cell deficiency, would require further management in terms of conjunctival limbal autograft, SLET, or CLET. So let's look at the limbal transplantation techniques. The conjunctival limbal autologous transplantation was traditionally popularized in 1989 by Kenneth Kenyon and Professor Seng. In this technique, two large conjunctival limbal lenticules are harvested from the superior and inferior limbus from the healthy eye, and they are directly transplanted to the affected eye. Unfortunately, this is known as CLAO. This is known to be associated with complications like iatrogenic limbal stem cell deficiency. But this procedure has the longest track record, and it has been shown to be successfully restoring the corneal epithelium in approximately 75% of the cases. If we talk about CLET, this was this cultivated limbal epithelial transplantation was popularized by Pellegrini and group in 1997, and here they used 2 millimeter by 2 millimeter limbal biopsy from the donor eye, which is expanded ex vivo, and then for about 2 weeks, and then it grows into a sheet of epithelial cells and then transplanted onto the surface of the affected eye. But though it has minimized the problems of CLAO, cell expansion necessitate clinical grade laboratory and a lot of regulatory approvals, which was still and is extremely expensive to build and maintain. So then in 2012, Sangwan and et al., they described an innovative technique of simple limbal epithelial transplantation, which is also known as SLET. which combined the advantages of CLAW and CLET while avoiding the limitations of both the approaches. Since then, SLET has become the preferred technique of limbal stem cell transplantation. We'll look at the video in a short while. Here, what is done is 2 by 1 millimeter limbal tissue is harvested from the donor eye, and then it is cut into pieces and transplanted onto the recipient eye in terms of 8 to 12 pieces, and then it slowly grows over the cornea. Several modifications were popularized, like customized SLET, sandwich technique combined with conjunctival autograft and combined with MMG when there is lot of symblepharon formation or if there is paucity of conjunctiva. A lot of papers are there about the success of simple limbal epithelial transplantation, and this was a multi-center trial where they looked at, that the success was much more when there was no symblepharon as compared to the patients who had associated symblepharon. The other group also looked at autologous limbal stem cell transplantation, a systematic review of clinical outcome with different surgical techniques like CLAW versus CLET and SLET. And they looked at and they realized that the autologous limbal stem cell transplant for unilateral limbal stem cell deficiency showed anatomical and functional success rates of 69% and 60% respectively without any serious adverse events in the donor eye. And the anatomical and functional success rates of SLET was 78% and 68.6%, and CLAW was 81% and 74.4%, and they were comparable and significantly better than those of CLET. So obviously these two techniques are much more popular in the clinical scenarios. They also looked at the economic analysis, and it was if we just analyze that in broad terms, the cost of SLET is approximately 10% of the cost of CLET for adults and 8% for the children, as you can see here in the bar diagrams which are displayed into the slide. So to simplify that, whenever there is conjunctivalization in the peripheral part with partial LSCD, there is no need of SLET, or one can go ahead with conjunctival autograft. If there is conjunctivalization of the peripheral cornea plus central corneal superficial stromal haze, one can decide for CAG, conjunctival autograft, and SLET. And if there is a total LSCD but not much of a central corneal scar, SLET would be a good option. So this is a very pictorial picture showing where we should use SLET and CAG and where we should not do SLET at all. We look at the clinical case scenarios. This is a 10-year-old male who presented with symblepharon with restricted eye movements, as you can see here in the clinical picture on the right-hand side down. And he required a symblepharon release, pannus resection, and because this was not involving rest of the limbus, we continued with CLAW, that is conjunctival limbal autograft. A small amount of limbal tissue was taken, and you can see that in the clinical pictures here, that the limbus is reconstructed very well. This was a case of bilateral acid injury, but one eye was less affected than the other, and in one eye, the eye which was more affected, he developed pannus formation, as you can see here in the clinical pictures. But since he had a bilateral injury and this was relatively a limited involvement, we decided to go ahead with a conjunctival autograft rather than doing anything. So he underwent that particular procedure, as you can see here. And you can see that the cornea has become very clear and his vision improved from 624 part to 69 part. And the eye has been very quiet in a couple of weeks' time. So you can choose the procedure accordingly. This is a very recent case, right eye of bilateral acid injury patient, responded to bandage contact lens and medical management initially. But later he developed localized limbal stem cell deficiency with recurrent, you can see the hemorrhagic areas also, recurrent redness, watering and pain. Here again it was a bilateral but less affected, the other eye was less affected. We decided to take the graft from the same eye, and that was taken from the supratemporal area, and it is transplanted here, as you can see here, and these are the 2 weeks follow-up pictures of the same eye. So he underwent pannus resection plus just the conjunctival autograft. We did not take limbus. Here we took the conjunctival graft 2 millimeter away from the limbus so that not to jeopardize the stem cell niche of the same eye, as you can see here in the marking areas. This was another case where you can see a patient of Lyme pest injury with very severe symblepharon formation, and almost the lower lid is attached to the limbus, to the bulbar sclera, and only 1 to 2 clock hours of limbus is free of conjunctivalization. He underwent pannus resection with SLET. As you can see here, the pannus is resected all throughout 360-degree. This is a donor eye from where we are taking 2 by 1 millimeter, 1 clock to 2 clock hours of limbus. First, we mark the conjunctival areas, and we harvested 2 conjunctival grafts. And this is the area where we are taking the dissecting the limbus into the cornea, and this is the limbal tissue which is harvested. This area, the donor area, is closed with fibrin glue and a bandage contact lens. And now we are back on the recipient eye, and you can see that first we apply the conjunctival autografts, covering the area where there was significant amount of symblepharon formation, the lower lid part. After both the grafts are applied, an amniotic membrane is applied all over the surface to allow the limbal pieces to be placed onto the cornea eventually, so that the amniotic membrane works as a basement membrane for those limbal tissues. You can see here it is very well fixed. And then now the limbal biopsy tissue is divided into almost 8 to 10 to 12 pieces, and then it is placed in such a manner that you have 2 circles, and then that is fixed onto the cornea with the tissue adhesive fibrin glue, both the components one after the other, and then a bandage contact lens is placed. So these are the post-op pictures. You can see that pre-op and post-op, the patient improved very well. This is the final, the donor eye, and on the left-hand side, the recipient eye. The ocular surface has been stable for past 5 years, and BCVA improved from 630 to 69 part, as you can see here. This is another example of chemical injury where he underwent multiple procedures for acid injury. He developed symblepharon and conjunctivalization in the inferior part, shortening of the fornices, as you can see here. Here we used donut-shaped, AMG, because we didn't want to touch the central area. So, and almost all the slat pieces were arranged much closer to the area where there was more of a limbal stem cell deficiency, and you can see a post-operative outcomes. These would not come in a couple of weeks. It would take few weeks to few months for the post-operative results. So you have to convince these patients and counsel them very well. This is an extreme case of LSCD, 360-degree with total conjunctivalization and a little bit of central scarring. To our amazement, even the central area looked much better. But now with the availability of anterior segment OCT, you can pre-decide what is the involvement of the corneal tissue before planning the surgical procedure. This was another case who was he sustained chemical injury almost 30 years back with a disinfectant powder, and he was having recurrent cheline. Conclude. I think I'll conclude in a couple of slides only. And these are the post-op results. Sometimes if you have a central corneal scar, maybe you have to follow it up with, after the slat, you can take these patients for PK or DALK, and the results are very good. One of the publications from RP Center talks about it, that 72.72% patients had good visual outcome, and success rate was almost 54% in these cases. And this is my last slide. As you can see here, this patient underwent multiple reconstructions. You can see the lids also. The lids underwent reconstruction, the face, the nose. As you can see here, I've been following him up from 2009, a very severe chemical injury from a very big company in Gujarat. And you can see that many a times the reconstruction or rehab would go on lifelong for such patients. With this, I would like to summarize: one should choose the surgical procedure carefully for individual case and its needs. Proper counseling of the outcomes and long-term results will lead to satisfactory results for both patient and the surgeon. Thank you very much for the kind attention, and I would like to invite you to Caracon 2023, which will be held at Chandigarh in December 8th, 9th and 10th. Thank you for the kind patient hearing.
Okay, thank you, Dr. Poros. For the interest of time, this question and answer session will be kept at the last. So our next presenter is Dr. Aditya Pradhan. He will be talking on ocular burn classification and overview. Over to you, Dr. Aditya.
Yeah. Very good morning to all of you. So I'll just start with the presentation. We'll take a quick overview at the classification of ocular burns. I have no financial interest to disclose. So basically anything which is caused by a chemical or a radiant energy injury is called as an ocular burn. So as we all know, it's a true ocular emergency, and extensive damage, and it causes significant morbidity as well. Sometimes it can lead to blindness if not properly treated on time. In developed countries, the incidence ranges from 1.25 to 4.4%. And here in countries like India, it is much more. And more commonly seen in men because of either workplace associated injury or at home or in assault as well. So if you see the data from the Western countries, the household cleaning agents, personal care products, automotive chemicals, glues and adhesives, they form the bulk of the causative agents in ocular burns. And in the household group, we have bleach and disinfectant hair products, which also cause significant amounts of chemical injury. And in the United States, if you see, there is a bimodal distribution peak. So one peak is in between 0 to 5 years of age in the pediatric age group. And then again, as the person starts going and working outdoors, so maybe from the age of 15 till the age of around 45, we have a second peak in which there is a lot of morbidity to the surface. And with time, as the age increases, the incidence of injury goes down. So in India, we have very few data. This is an old article from 93 in which again alkalis were around 36% of the cases, acids were 48%, and then some miscellaneous agents. But as you can see, the factory workers, those and working in the laboratory as well. So they were significantly affected by this. And this is the article from RP Center. So we have data for the pediatric age group as well. So patients aged less than 16 years were included in this. So in the preschool group, the injuries were more severe and were associated with severe visual loss. Alkali injury from the bursting of tuna packets was the most common cause of injury in the pediatric age group in North India. So if we go to the classification, we have a timeline which started with the article in 1964 by Ballen. This was modified by Roper Hall, which is called as the modified Roper Hall classification. And briefly, one article came out in by Pfister in ophthalmology, which showed you have to match the presentation of the eye with the pre-printed photographs. And now currently, which we are all using is the classification by Dua, which came out in 2001. So if we have the Roper Hall classification, we have only 4 grades in which we look at the corneal epithelium, we look at the conjunctiva and the limbus, and then the prognosis ranges from good to poor in grade 4. And this is the Pfister classification which we don't use, but we have to just match the appearance of the eye with these photographs. So it's not very accurate, but maybe just to get a rough idea at maybe a primary care center, you can use this classification. And then Dua modified this and we have 6 grades now. So the prognosis ranges from very good to very poor. And number of clock hours of the limbus involved is what we see in the clinical findings. We also look at how much percentage of the conjunctiva is involved. So, but we all know this classification is somewhat incomplete. But the prognostic value of Roper Hall and Dua classification is, Dua is better because it subclassifies into the grade 4 into 2 more, grade 5 and 6, so it is more comprehensive. So what is new in the classification system is the calculator which was introduced by Dr. Geeta Iyer and group from Shankar Netralaya. So this is based on the I&E system of management of ocular injuries, in which this part is the conventional which we all know by Dua, L1, 2, 3, 4, 5, 6. This is the EPICS. EPICS is, E stands for epithelium. We have 3 types of epithelium which are damaged by chemical injuries, that is conjunctival, corneal and tarsal epithelium. Then P stands for pressure, I stands for ischemia, and X is the amount of exposure especially if the lids are involved. And based off that, there is an online calculator which I'll just show a screenshot. So this is the freely available calculator on the website, in which you have to just enter these few demographic details. Is it a unilateral or a bilateral involvement? And then you have these drop-down menus in which you have to select the amount of injury as per what you see on the slit lamp. And then it gives you the grading and the prognosis. So as we all know that since the time of Dua's classification, that limbal ischemia is the most important factor, prognosticating factor in the final outcome of chemical injury. But we still don't have a reliable assessment that somebody may call it ischemia, somebody may call it blanching. So we still don't have a reliable system. So as you can see in the top photo, that is P1, on the top left, it is definitely there is a lot of corneal involvement, but the conjunctiva is sort of blanched. But if you look at the bottom left and bottom right photographs, this whitening is definitely ischemia. So there is sometimes a confusion in the very early phase of injury that what is blanching and what is frank ischemia. So there are being certain modifications which are being proposed. One is which is using the fluorescein angiography for the anterior segment, in which you can just push the dye like our retina colleagues do and then take photographs of the anterior segment, see where the ischemia is, and then perform tinonplasty more selectively rather than performing a near total procedure or a more severe procedure. And the next modality on the block, again inspired by our retina colleagues, is the OCTA, that is the anterior segment optical coherence angiography, in which no dye is needed, but that is definitely more reliable than just clinical examination. So there are certain articles which are now coming out in the British Journal and other articles. So this was a pilot study. So they concluded that it was objective, a non-contact method, rapid assessment of the vasculature compared to that done by the clinicians on the slit lamp. Yeah. So this was another article in 2022 in which they have done serial photographs, both with fluorescein stain and the angiography. And they have shown that what we see on the slit lamp, the OCTA reveals much more in terms of the limbal vasculature. So now, which seems much severe on day one, you can see that the vessels have started crumbing back. So most likely it was blanching. And here you can see this is more severe, that is the ischemia. And then even with conservative management, certain cases do heal, but sometimes we tend to overestimate the grade of injury. So the clinical examination alone is insufficient to assess the presence and extent of ischemia. So, and obviously one more study now published this year has shown that it has more impact and more sensitive than just clinical examination alone. So we need more awareness. Prevention is the best cure. So we need more awareness campaigns, that especially the handling of tuna packet by children. So the take clinic message is it's a true ocular emergency, as we all know, and we need a newer classification system which includes the depth of scleral ischemia for better treatment and prognostication. And if you use a OCTA, which is very difficult because the machine is expensive and not available everywhere, still we don't have a standardization and accuracy and whether it is reproducible and reliable in different clinics across the globe. And with this, I would like to invite all of you to next year to Kolkata for AIOC2024. You can scan the code for payment and get a discount till 14th May. Thank you.
This presenter will be by Dr. Aditya Bajaj. He will be talking on this medical management of ocular burns. Over to you, Aditya.
Sir. Good morning, everyone. Today I'll be talking about medical management of acute chemical injuries. Ocular chemical injuries are true ophthalmic emergencies that require immediate and intensive intervention to minimize severe complications and profound visual loss. These severe complications occur due to a non-healing corneal epithelial defect in the acute stage, and in worse situations later, corneal scarring, perforation, and later on glaucoma. The presence and extent of epithelial defect is the one effect of chemical injury that determines the severity of the injury, the various sequelae that are to occur, and the severity of inflammation. In other words, inflammation and epithelial defect are mutually inclusive factors that determine the final outcome of a chemical burn. The primary aim of all therapy is to re-epithelialize the ocular surface. The first and foremost important step is the removal of the inciting agent by copious irrigation. The basis of doing so is to normalize the pH to less than 7.4. So the irrigation is done with tap water in the pre-hospital setting, and once the patient reaches the hospital, even before you have seen the patient, or rather than making the patient wait for the optometrist to see, they have to be taken directly to the procedure room, minor procedure room, and the eye has to be irrigated with ringer lactate. And commercially available pH paper is available, and you can check and do the irrigation till the pH is almost till 7. Never neutralize an acid with a base as it causes more damage. And in lime and tuna injury, examination under anesthesia is mandatory in children and in uncooperative adults, because especially to look at the fornices. Some suggest paracentesis and removing an aliquot of aqueous and reformation with buffered phosphate solution can lower the pH by 1.5 units in case of alkali injury. Diphoterin or Prevor, it is a proprietary amphoteric solution, and it has been heralded as a universal emergency irrigant, but which is not available here. So large chunks of tuna like this can be manually removed with forceps, and then the irrigation continued. And pultaceous matter which is stuck adherent to the conjunctiva, this is a cement injury. So these can be loosened first by irrigating with a low strength EDTA solution, and then removed with cotton buds. Now, control of inflammation is vital, and for this, topical steroids have to be given, and that is the mainstay of therapy in the first week to 7 days, first week to 10 days following the injury. There is a risk of accelerating a sterile melt by use of topical steroid. However, stopping the steroid can be equally detrimental to the process. So, in case you are continuing topical steroid beyond 2 weeks, then it has to be combined with an amniotic membrane grafting. The choice of topical steroid depends on the severity and the strength of the chemical injury. So a stronger steroid like prednisolone acetate or dexamethasone is required, or a weaker steroid like fluorometholone or loteprednol in minor injuries. Intraocular pressure rise can be treated with the topical alpha beta blockers. Oral carbonic anhydrase inhibitors can be given if the patient can tolerate it. In rare cases, a beveled paracentesis may be required for urgent lowering of the IOP. But also assess for steroid responsiveness. Quite a number of patients will turn out to be steroid responders, and this has to be checked on regular follow-ups. Lid position and periodic blinking are usually disturbed temporarily even in the mildest of injuries. So non-preserved tear substitutes are required for symptomatic relief, especially CMC 0.5% or 0.3% HPMC eye drops. A strong mydriatic should be given to relieve ciliary spasm, and prophylactic antibiotic eye drops can be given 4 times per day, or antibiotic ointment at bedtime. For pain management, a simple bandage contact lens can be applied. Pain management is not very complicated because it is very short-lived because of the destruction of pain receptors. Oral NSAIDs can be used, but topical NSAIDs should never be used. Photophobia can be extreme, and it usually requires dark glasses. During the repair process, the fibroblasts invading the cornea are usually immature, and the collagen produced by them is underhydroxylated. And this tissue characteristic is sine qua non of localized tissue scorbutus. So this ascorbate deficiency, it causes a faulty repair process, and it tips the destruction repair ratio towards tissue disappearance, and hence corneal ulceration. So 10% topical ascorbate, if available, can be given, along with 1 gram ascorbate orally per day up to the time of re-epithelialization. And it has been shown that ulceration is diminished by this therapy. Transitional stage begins from as early as 1 or 2 weeks in milder injuries, and as late as 1 to 2 months in severe cases. And a persistent epithelial defect is usually due to limbal stem cell deficiency, persistent inflammation, and exposure. At this time, drug toxicity is an important cause of PED. Preservatives such as benzalkonium chloride and ointments containing lanolin can perpetuate or create new epithelial defects. So it is wise to avoid topical treatment with multiple medications in hope of preventing corneal ulceration. Cysteine and acetylcysteine are both effective inhibitors of collagenase, and it can be used at this stage. And acetylcysteine is more readily available in the form of mucomist, 10% or 20% solution. It should come in 7 days after the injury. For PEDs, autologous serum eye drops have made a comeback, and it is a method of establishing epithelial integrity by growth and migration. It can be used every 2 to 3 hours initially, reducing to 4 times a day, and only stopping weeks after the defect has disappeared. And failure of epithelialization at this stage means that a stem cell deficiency has ensured. Citrate, as an alternative, it acts as a chelator of extracellular calcium and virtually halts all neutrophilic activities, and it helps corneal ulceration. And it can be given, if available, in the form of topical eye drops. There are some newer alternatives like fibronectin, albumin, and epidermal growth factors, which have shown tremendous response in laboratory studies. So, if there is a repeat melt, then a repeat corneal amniotic membrane grafting can be done. Oral doxycycline 100 mg twice daily and then once daily, along with tetracycline ointment 4 times daily, acts as effective collagenase inhibitors and inhibits neutrophil activity. Any perforation at this stage has to be surgically managed. So, in summary, no effort should be spared in the management of acute chemical injuries. Primarily, efforts have to be made to restore epithelialization and reducing inflammation, and also to reduce the intraocular pressure. Unaddressed ischemia and exposure has been the cause for non-healing defects and melt. Providing an alternate source of cells in an eye with a severe grade injury is of paramount importance. Finally, a limbal epithelial transplant may be required along with a lamellar or a full thickness corneal graft. So I would like to invite everybody for All India Conference 2024, and the registration is open. Thank you.
Okay, very informative talk, Aditya. Now, Dr. Soham will be talking on amniotic membrane transplantation.
A very good morning, everyone, and a very big thank you to Dr. Tuhin for including me in this instruction course. So I'll be talking about the role of amniotic membrane transplants in acute chemical and thermal injuries, no financial interest. So the use of AMTA for chemical injuries has been around for the past almost 80 years. And in the late 90s and 2000s, it's become really popular. Now, if you look at it histologically, it's very similar to looking like a cornea. You have got the epithelium, the stroma, and also the collagen structure is very similar to that of the corneal structures. And the mechanism of action is basically more of both physical and a chemical kind of thing going on. So there's no immunogenicity, no chances of rejection. Translucency allows us to evaluate the clinical progress. It retains moisture, and also there is a load of chemokines which really promotes epithelialization, prevents fibrosis, has anti-inflammatory properties, anti-angiogenic properties, and also a slight amount of antimicrobial properties. These are the types of surgeries where AMT is used. For chemical injuries and thermal injuries, we use the onlay or the overlay technique, where the amniotic membrane is essentially used to cover an unhealthy surface and to promote the healing process. Commonly used is the freshly prepared and preserved kind of AMT, which usually is made in the labs. Cryopreserved, lyophilized, these are less available in our country. And coming to the delivery systems, the freshly preserved amniotic membranes are usually stored in the Dalbaco medium and are attached to nitrocellulose paper. Then we have this Amcerter from Orolab, which is like a sort of a slot system to hold the amniotic membrane sheets. Procera is commercially available. You can also suture it onto a symblepharon ring for better attachment. And amniotic membrane extract drops have been experimented with, but this came in last month. So the indications of amniotic membrane in chemical and thermal injuries usually recommended for grade 3 or more of the DUAS classification, any persistent epithelial defect after conventional medical management, risk of developing a symblepharon or keratoblepharon. Now, there are quite a few publications which challenge the use of AMT over a medical management alone, but we'll leave the debates aside. The basic surgical principle is we start with the meticulous debridement of the surface, take care of any particles, especially tuna particles which might be embedded. The entire or the partial surface is covered. Usually covering the upper and the lower lid margins to prevent symblepharon is recommended. Can be secured with Vicryl or nylon. A purse string suturing at the limbus to secure it over the cornea. Now, using a fornix deepening sutures, a symblepharon ring and tarsorrhaphy, this might be done case-to-case basis. The common orientation of AMT is usually we put the sticky stomal surface on contact with the cornea, though few publications say otherwise. So we'll take a few video examples. So this is a workplace injury with both chemical and thermal components. This is the versi involved. So start with debridement, and then the amniotic membrane is placed over the affected surface, and you can see peeling it away from the nitrocellulose paper. And I'm securing it with fibrin glue for better retention. So this step, if you have glue, you can do it. It's not a mandatory step. But ensure that you're covering all the surfaces which are involved due to the chemical or the thermal burns, especially the lower fornix and the lower conjunctiva, which has more prone to forming symblepharon. Dry the surface well before applying the glue. And then this is passing off a purse string structure. I'm using 10-0 nylon here. So you can put maybe 4 or 5 bites all around the cornea so that the amniotic membrane stays well centered. Following which, I proceed to cover the lower fornix. Again, applying a little bit of glue for having it better secured. Now the following step is most important, making sure that this entire conjunctival fornix is covered. So I'm using a muscle hook to sort of ensure that the amniotic membrane stays in place. Hold it in for a couple of seconds, allowing the glue to dry. Now if there is inadequate fornix here, you can put fornix deepening sutures at this point of time. But in this gentleman, there was good fornicial depths. And finally top it with a bandage contact lens. This is an alkali burn in a young girl, presented quite late, so here there is extensive opacification of the cornea and also some amount of conjunctival ischemia. So definitely those tissues have to be removed. And then the tenons and the loose conjunctiva is secured with glue. And followed by amniotic membrane as shown in the previous video. In this case, since there was good conjunctiva otherwise, since it's a late presentation, you can just trim off the excess amniotic membrane and it can be only a small area of amniotic membrane cover. And in this child, I did not use a bandage contact lens initially, later on I put it on. This again also shows the importance of removing the dead tissues, basically, which sort of inhibit in the healing process. So anything that you're seeing white after a chemical or a thermal injury needs to be debrided. Dr. Tuhin will be talking more in details about this. So you basically excise till you see the bleeding points. Again, this is how the amniotic membrane comes in nitrocellulose paper. So you can then take the sheet and apply it easily over the affected surface. And also make sure to check under the lids because often you have these membranes developing over time. So follow-up management is very similar to conventional therapy already discussed by our previous speaker. The healing process is important. Amniotic membrane usually self-disintegrates over the 4 to 6 weeks, and we can check the epithelialization process either using fluorescein or using the anterior segment OCT. We have to do a close follow-up to monitor LSCD and symblepharon formation. This is the same child from the second video. So this is at presentation, presented quite late. This is immediate post-operative period. So this is the ASOCT. This is immediate post-op. You can see the bandage contact lens. Then the next thick layer is the amniotic membrane. At 2 weeks, you can see there's a lucid zone forming in between the corneal stroma and the amniotic membrane. That's the newly developing epithelium. And also the amniotic membrane has thinned out over time. So it's slowly disintegrating. And this is 3 months post-operative of the same person. Complications, symblepharon, vascularization, and LSCD are commonly encountered. But what amniotic membrane prevents is, it prevents progression of symblepharon. So this symblepharon has sort of remained the same even 2 years after the surgery. So finally, to conclude, so we need a good, reliable source of amniotic membrane Good debridement is definitely the key to a successful surgery. While literature may challenge the use of added benefit of amniotic membrane, practically it is definitely a good outcome. Then this is the survey of ophthalmology major reviewed from the RPC group. So they recommend use of amniotic membrane in anything 3 or more of Dua classification and also to be done at the earliest. Thank you very much.
So nice talk, Soham. So now I will be talking on role of tenonplasty, slate, scleral patch graft in acute chemical and thermal injuries. I have nothing to disclose financially. So already covered that the primary goal of this ocular burn is that promote ocular surface healing. That is the reepithelialization of the surface and to control the inflammation. Along with that, we have to address the two another parts, that is the scleral ischemia and exposure of the sclera. So surgical therapy that this promotion of the reepithelialization. So by AMT, Soham has just explained it lucidly. Sometimes if we don't have any sort of AMT or amniotic membrane grafting, then we can put large diameter bandage contact lens, 16 millimeter or 18 millimeter. Sometimes we have to go for this conjunctival or this tenon's advancement, that is tenonplasty or alloslate, or even sometimes conjunctival transplantation. So in presence of scleral ischemia, that is a blanched out white appearing sclera, that here this is this blanched out white appearing sclera. So here only amniotic membrane transplant will not suffice, so these patients need tenonplasty. So what is tenonplasty? So in 1989, Tapping and Rhyme first reported use of tenonplasty by stretching and advancing a viable and non-ischemic pedicle tenon graft from the adjacent fornix, and that way it halts the progressive scleral melt and to facilitate conjunctival healing. So in this video, what you can see that we are just removing this this necrotic conjunctiva as well as sclera, and then taking this healthy tenons separating from this overlying conjunctiva, and then suturing it near to the limbus. So it is considered as a globe-saving procedure that helps and accelerates reepithelialization of the cornea and conjunctiva through limbal perfusion. So you can suture it by using 6-0 or 7-0 or even 8-0 vicryl suture. You have to excise this necrosed tissue. So sometimes you cannot suture it in this limbal area. This is the patient, 52 years man, who had burn injury 6 days ago. So then you can see this, there is extensive scleral ischemia, and this is the video here. This is the totally charred tissue here, totally charred area. So you cannot take these tenons from here and suture it here. If you suture it, it will chisure, or you cannot pass the sutures, or it will just gape away. So what we have to do that, we have to put an amniotic membrane graft here, and then take the tenons, put these tenons together over the amniotic membrane, and then put another piece of amniotic membrane. This is called modified AMT. Just see the video. Now suturing these tenons pedicle graft over this amniotic membrane. And then put another piece of amniotic membrane over the this bare tenons area. And then you can put a bandage contact lens here. So this was the patient after 10 days. So this amniotic membrane is getting disintegrated. And this is the picture after 3 weeks. So now after 6 weeks, this patient developed this large epithelial defect. At this visit, I started on autologous serum. And this patient after 3 months, but the scleral part, necrogenic part is getting better now. And after 6 months, this sclera is getting vascularized. And this is the picture after 2 years. So now patient from PLPR now to 636 patient now. This is another patient who had this paralimbal thinning along with extensive scleral necrosis along with this corneal thinning. I did the same way this procedure of this modified technique of limbal transplantation, at least tenonplasty. And unfortunately, due to lockdown, patient didn't turn up. And so same way this tenons was that means sutured over this amniotic membrane. We can use this as like plastering suture or like just two adjacent tenons, same way. Put another piece of amniotic membrane. In these cases, you should put a conformer and then tarsorrhaphy. This patient lost follow-up, and then after 40 days, patient came with perforation, but you can see that this scleral ischemia part is better now. So on that day, I did this therapeutic graft, and this is the picture after 21 days. And this graft was oil taken up. So after 4 months, there was this persistent epithelial defect. And then after 9 months, this is the picture now. So sometimes we have to repeat the procedure as these sutures may gape away or just stitch wearing will be suture. And then we have to combine this alloslate or oral MMG. And when the globe integrity is restored and ocular surface is stable, then we can plan for further surgeries for better visual rehabilitation. So in acute chemical injury, that can lead to persistent corneal epithelial defect and because of delayed surface epithelialization. So epithelialization of the cornea helps to prevent stromal thinning, scarring, and reduces inflammation. This is the patient, 9-year-old boy with Chuna injury. So we did this aimed with tenonplasty, but even after 3 months, you can see this persistent epithelial defect here, along with this similar formation. So what I did that, I did this cadaveric slate. So cadaveric slate that just like this, taking these pieces, not from the healthy eye, from this cadaver, that means this freshly retrieved tissue, and then we can take this limbus from that cadaveric eyes and then put over this just like slate, we just put over that area of PED. And this is the picture now. So this was, that means postulated by IR et al. That alloslate seems to be a useful technique to achieve rapid epithelialization in severe chemical injuries, thereby preventing the adverse effects of delayed epithelial defects. And no doubt these eyes should require a subsequent limbal autograft following a failure of the transplant, because this cadaveric slate, it will be failing definitely. So you have to go for again limbal transplantations. But the thing is that this, because of rapidity of epithelialization, it can be practiced. The healing of the corneal surface with an underlying clear corneal stroma with tracking feature, thereby reducing the need for further keratoplasty like penetrating or DALC in these cases. So another case that, as per Wang et al., that the buccal mucosa in histology and physiology resembles the conjunctiva and is considered a suitable substitute for the conjunctiva and in repairing sclerocorneal ulcers or smells in serious corneal burns. However, free oral buccal mucosa doesn't improve the local ischemia of the sclera or limbus following chemical burns, and so should be combined with tenonplasty. So here the reasons for tenonplasty is that it can improve the local microcirculation, and this MMG provides many cells like these conjunctival cells and even for this epithelialization. This is a patient, this 40 years man who had bilateral thermal injury 4 weeks ago. This patient, other eye became thoracical, and then patient came to us. So here, this is the previous picture. So total this limbal ischemia, scleral ischemia, along with this corneal involvement. So what I did that, I did this tenonplasty along with this MMG. MMG, because it is just like it is getting thin day by day, so that's why this is the picture after 1 year. This is quite, this patient's vision was not so much affected previously, but this eye is restored now. So we have to address this scleral exposure also. This patient who had this lead defect, so I did this tenonplasty, and then after a few months, this lead procedure was done by our oculoplasty colleague, and then patient, this lead was better, and then I did this congenital autograft from other healthy eye, and this patient is getting good vision now. So you have to remember that in patients who had this frank perforation, so in these cases, this tenonplasty will not help. So these patients need scleral patch graft. So this is a patient who had this scleral defect. So we took this sclera, and then we have to go for lamellar dissection, and then suture it by using 60 Vicryl. And then over the patch graft, we have to put this congenital autograft from the other healthy eye. So this is the picture after, that means this after 1 year, patient is doing fine now. So one should remember that if there is thermal burns with scleral perforation, so tenonplasty won't help in these cases. So these patients need close follow-up after the initial injury for management of possible sequelae, corneal ulceration or perforation, corneal scarring with limbal stem cell deficiency, secondary open-angle glaucoma, conjunctival scarring or similar foreign formations. These patients may have dry eye, and exposure due to lead malposition from the secondary cell changes should be addressed. So to conclude, proper management in the acute stage is most important, and that determines the long-term outcome. When the globe integrity is saved and ocular surface is stable, one can plan further surgeries for better visual rehabilitation. Based on severity and laterality, many options are there. Glaucoma, the most common comorbidity, and needs to be addressed aggressively. Thank you for your time. Now, Dr. Binoy will be talking on this bilateral visual rehabilitation in late cases. Over to you, Dr. Binoy. To be here. Next step.
Good morning, everyone. So the topic is late visual rehabilitation in bilateral ocular burns. Well, options are very limited in such situation. Probably what we should think in any case of visual rehabilitation post chemical injury is, are the adnexae okay? If not, we may have to reconstruct the lids. What about the conjunctiva and fornix? Then again, we have to kind of think about a reconstruction of the fornix. There has to be a source of epithelium to epithelialize the entire ocular surface. We may have to think about conjunctival autografts, mucous membrane, and then limbus, or even cultured mucous membrane transplants. And finally, we think about we really think about visual rehabilitation in terms of restoring the limbus and the corneal epithelium, provided the stroma is clear. So in cases like this, where there is reasonably good adnexae, stem cell failure, visual recovery is partial or severely affected because of the pannus or anything, one option which is really underutilized is scleral contact lenses. Okay, we may not have to intervene at all in many of these cases if we try scleral contact lenses, where there is a significant amount of visual recovery is obtained. So unilateral has already been dealt with. Stem cell transplant, if it is autologous transplant, if it is a moist normal eye, if it is a dry or adnexae is severely damaged and the other eye is normal, probably it is not worth attempting any restoration or any reconstructive surgery in such eyes. Bilateral, again, if the adnexa is normal and moist eye, you can think about stem cell transplant, but the only option is allotransplants. It can, in the sense it can be a keratolimbal allografts, SLET, clet, cultured cells. But the problem with allo stem cell transplant is immunosuppression, especially in our setup, in our in our society. It may not be a good option because of all the problems of immunosuppression. The major being the expense, the second thing being the the immunosuppressive states predisposed to infection and other things. So not a great preferred option. But then yes, in such desperate situations we may have to. Comet or cultured mucosal epithelial transplant has also been tried. It does bring about some kind of improvement in vision, but it doesn't bring about a great improvement. So the other real practical option is keratoprosthesis or Boston type 1 keratoprosthesis. This is attempted only in eyes where the adnexa is normal and you have a reasonable good amount of tears. The success rate is relatively good. Again, it is not an option if the other eye is normal. Okay, we think about keratoprosthesis or any of these surgeries only if both the eyes are affected. So what happens when the eye is, there's severe damage to surface, adnexa and the surface with associated tear film or dry eye? The only option will be one of the, the surgeries which mentioned there, like an osteodontokeratoprosthesis or a type 2 keratoprosthesis. Now, why we prefer it in dry eye is because the design of the prosthesis, and then, it's really cumbersome. If you think of keratoprosthesis, it can be biological or non-biological. Biological, the most common one, or the one which is having a real good outcome, is the modified osteodontokeratoprosthesis, where we use a tooth root. Non-biological, again, Boston is the most accepted one. So type 1, as I mentioned, you do it when the adnexa is normal and the eye is moist. If not, we have the option of MOKP or type 2. MOKP is done in 3 stages, long, spread. The first stage is basically a preparatory stage. You remove everything in the eye, then assess, cover the surface, and then, I have to rush through because of the interest of time. So that is the first stage, and then the second stage, you take the cheek mucosa and cover the surface with the mucosa. That is 1B. Then 1C, we take the tooth root. It's preferred is a canine tooth. Harvest the canine tooth with the root. It's the root and the bone which is fashioned into thin lamellae, to the center of which we drill a hole and fix the optic cylinder. So this is then implanted in a subcutaneous pouch, usually over the orbital area, and left there for about a couple of months or so. It gets a good fibrovascular capsule. And then in the last stage, where you harvest it from the cheek and put it on the eye. Cosmetically, the patient looks actually horrible, but then the visual recovery in these cases are quite good. So most of these stages take long, 5 to 6 hours of surgery at least. And yes, we have started it here, but then this is actually represented as a Steven Johnson patient, not a chemical injury, but then in extensive surface damage with a tear film problem, this is the only option, or this is the, if I say so, the best in inverted comma option available. Now, what about, this is again a Stephen Johnson, but not a chemical injury, but what about in cases like this gentleman who has very bad teeth, or if, as I mentioned, OKP requires multiple stages, long durations, anesthesia problems are there. If he's not fit, then type 2 keratosis is the option. The advantage is it's a single stage procedure. It's a, it's unlike type 1, it can be performed in the eyes with severe dryness. So here the cornea is used as a carrier, and then the difference from type 2 is you close the lids on the prosthesis. There is a protrusion from the surface of the prosthesis which can come out through the tarsorrhaphy. It needs a total vitrectomy and AGV in all cases, because the chances of secondary glaucoma is very high in these cases. So this is the composite prepared, and this is how it is sutured, and then finally you close it with lids. And this is the a protrusion which I was mentioning on the surface. So, and a total tarsorrhaphy is performed on the surface to cover it. So, yes, visual acuity in these keratoproses are, recovery is good, but then the problem is these are all potential time bombs which can have problems anytime. So these patients have to be committed and for a long follow-up or practically lifelong follow-up. So basically what in bilateral disease, what is the choice will depend a lot on the patient profile, the facility available, and how how comfortable you are with each procedure. Thank you.
So still now I have 2-3 minutes time. If you have any questions, we can discuss. Dr. Poros, can you come here? So if there is no questions, then we can conclude the session. And I thank all my co-instructors for their participations, and I thank all the audience for their presence. And now I request Dr. Jhanji to come here for a photograph. Okay.